This is our agenda today. We have some exciting presentations, and we're going to go ahead and get right to it with Joyce Marshall from the Oklahoma State Department of Health.
Barbara, appreciate that. So I will go ahead and begin. We have just a few updates we wanted to provide for you today. And first of all, I wanted to let you know a couple grant opportunities that we are applying for our state. So we'll hope to be telling you more in that regard. There's the ERACE grant, which is the enhancing surveillance to eliminate maternal mortality. So this grant will help enhance and standardize our state and national maternal data. So we hope we will be receiving this. Before, it was kind of limited to states who didn't have a current maternal mortality review committee, but it is not in this newest reiteration. So we are hoping, we are applying for that grant and hoping to bring it to the state. We also will be applying for the new maternal health innovation cycle to bring additional funds for maternal health innovation projects to our state. We've had a lot of success with the first reiteration with AIM bundles, Teen Birth, Maternal Health Project ECHO, the gap filling prenatal clinics, aspirin therapy campaign, Maternal Health Project ECHO, Tribal Maternal Fetal Medicine Clinic, Chest Health, and such activities. So we'd like to be able to continue those opportunities in our state. So I wanted to let you know about those. Hopefully there'll be more good news to come. Additionally, I wanted to talk a little bit about just quickly kind of show you where the prenatal care clinics were. So next, on our map, I was just laying, this is kind of showing where our gap filling maternity prenatal care clinics are. We have one in every rural district at this time, or is coming soon. So all the ones you see now, plus additionally in the next couple months, we should also see in the far northwest, the central northwest, additional in the southwest, and also in another one will be added in the far southeast. They're kind of where we don't currently have a lot of services available, and there's a high need there. So these are being provided to address that need and assist the communities with the prenatal care in those areas. Next, just a little bit, we wanted to talk briefly about our maternal and child health data portal. So you could see the information in relation to it. We wanted to let you know it is out there. The link is also on the slides that you'll receive, and I'll put it in the chat after I'm done. But it's just, it is a platform for quality health related data. You can access very easily from our site. It provides you quick access to relative maternal, infant, and children's health information. It has dashboards that you can move the characteristics, pick the characteristics you want to look at, the region you want to look at, and then see exactly what those rates and information are. Along with, there's also a port for reports, fact sheets, and infographics. And it has a variety of sources, both national, state, as well as some local, that you can pull up and review. And it is accessible for everyone. Next. So this is just really quickly how you can access the data portal. So you can, there's 3 different ways you can get to it quickly. So either the vanity URL, you can just click on it, it'll take you directly there. Also, you can go to our homepage for the health department and go to health education and either click on the MCH data portal or maternal and child health service, either one, and it will take you to the maternal and child health service homepage. Then you click on the data portal, and then it will take you to the actual portal. You can go into the dashboards, the fact sheets, infographics, or reports for your topic area, or external data sources for more information if you want to look more into the sources where it was pulled from. So again, this is the link, and next. So we weren't able to, we didn't have time to do like a live tutorial today, but I just wanted to show you a little bit, so a few examples quickly that you can, of what you can pull up. So like this is live births. You can look at it by graph. You can look at it by map. You can look at it by various characteristics next. Example of preterm birth, the rate also. In the actual portal, you can click on each entry point and it'll give you the exact number, source, and you can delve into it further and break it down further. So that's for each one. This also shows it by you pulling it up by race and Hispanic origin for preterm births. Next. This is when you're searching for the characteristics, if you put in for maternal age and birth weight, it gives you the maternal age group and also birth weight broken down by those characteristics, so you can see for each percentage. It's through 2022. I see in the data question down from Jill. Next. Here's another example of one that you can do, a map of those regions, and you can see what the ranges of the deaths. In the actual portal, you can actually click on each county. It'll give you the exact rate for that county. The same thing with the data points. So just a few examples of some things. There's many more, but those are just some examples of what is on the portal that you can go into and get information that you need. Again, here's another one in relation to linked infant death by gestational age for combined years of 2020 to 2022, by maternal age, maternal BMI, and maternal education, for example. Some of the ones we get lots of questions for. So I wanted to let you know that that's available and readily accessible for any and all of you to utilize as needed. Also wanted to quickly take this time to just let you know it's our Title V Maternal and Child Health Block Grant. We do a needs assessment for the entire state every 5 years as part of that grant on what the maternal and child health needs are for our state. And that is what we're currently getting ready to begin. So I wanted to let you know that we're in that process. We will be asking for your input. We get it from, try to get from all communities, all individuals, the population. We also like to get it from providers and partners to hear your viewpoint and what you think is critical, what you think is important, and why. So we will be gathering this data. We'll be doing it in different ways, and go ahead and do next. It helps inform priorities, how the funding is going to be spent based upon the needs and what the data and the needs of the communities are saying that they are. So there's, right now we are in the public input survey. And at the end, I'm going to give everyone, and I'll also put it in the chat, there's a QR code where you will have the opportunity to have your opinion matter, your voice count in relation to what you feel is important from the provider or partner standpoint, and what you see as the major concerns, what you're seeing when you're out in practice or you're working with various individuals. We'll be doing the same throughout the community. You can also, if you're serving various members, you can also provide this to them. It's available, like I said, it's available to anyone, and we're trying to get it as broadly dispersed as possible. We also will be doing this throughout the spring and summer. Listening sessions, we will also do some more intensive listening sessions with specific populations that we serve, such as tribes, geographic regions, communities, vulnerable populations throughout our state to make sure that we're getting their input also. And then there'll be key informant surveys, which many of you as key partners and providers may be getting a phone call or survey in relation to those to provide additional key information and also to make sure that we're getting provided what we need, where we need it, and to whom we need it. Next. Okay, and this is kind of the sheet with the QR code. So you can go to this QR code, it'll take you directly to the survey. And please, everyone that can, we would love for you to complete this and make sure we get your opinion in, your key voice, and we can use it to prioritize needs for the state in relation to Title V block grant funds that are distributed throughout the state. I think that is my final item. I've also got our Maternal and Child Health Assessment Division email and phone number. If you have any questions in relation to the survey, you can call or email at any time. And you can also reach out to me. I'm always happy to, but these are our experts in this area who are actually doing the surveys. And so they'd be happy to answer any questions that you have. And I think that is all I have for our updates for right now. Are there any questions? All right. Thank you, everyone.
Thanks so much, Joyce. That's very helpful information and a great way to find data quickly. So we appreciate that. Next on our agenda, we have Traylor Rains from the Oklahoma Healthcare Authority. He's the state Medicaid director, and Traylor is going to provide us some updates from OHCA.
Good evening, everybody. Good afternoon or good evening. Thanks for having me. So I don't have an official PowerPoint, but I wanted to give you an update on a few things that we're working on. As you probably know, we went live with our Sooner Select product on April the 1st. That's our transition to managed care for the majority of our population. The only exclusions to those that transitioned were our age-blind disabled population and a large majority of our American Indian population who chose not to opt into Sooner Select. But as of May 1st, we'll have about 600,000 individuals served through our new managed care delivery system. We did go live April 1st. All three of our plans are reporting paid claims. We understand that there are going to be some pockets of issues with providers as they iron out contracting arrangements with the plans, getting their payments set up, and working through claim submission and prior authorization requirements that may be new to them as we work through this. But everything is live. So patients have received their welcome packets from all the plans at this point that they've been either chose or were auto assigned to. So it's important if you work with members, Sooner Select members, to encourage them to bring their new ID cards with them to appointments and to the pharmacy. Something that we've identified too that we didn't do a lot of education around was really the members that remained under the Healthcare Authority's administration, and explaining to providers that you're going to still see some members that may not have an ID card from one of the affiliated plans, and that just means that they're still being administered, their health benefits are still being administered directly by the Healthcare Authority, but that they still have coverage. I wanted to just highlight, I think maybe it's come up in previous meetings, the transforming maternal healthcare model. That's an initiative through CMCS that they've announced preliminarily over the last few months. We literally just got out of a leadership meeting to talk about this. We're still waiting on official guidance from CMS to come down on parameters. We're expecting the notice of funding opportunity to come out. They were saying in the spring, which we're expecting to be the next month or so. But we are going to go ahead and start evaluating that more closely and reaching out to stakeholders and partners to help us identify the needs throughout the state, help us maybe with resourcing some data elements that will help with that grant application as we go out. So I would say kind of watch that space for more news as we continue to go down that path. Want to give an update real quick on our doula program. We did add coverage for doulas several months ago. We are having a slow uptake there. We're trying to work with the doula community and help them with provider enrollment. We understand that there may not be a comfort level with enrolling with an insurance company at all, much less Medicaid. So we're trying to do technical assistance and outreach around the provider enrollment processes with us, how to submit claims for reimbursement. Right now, we have 12 contracted doulas in the state that are providing services through our network, which we're excited about, but we really want that number to increase. And so that's why we're looking at things like this grant opportunity that can really build a sustainable model for not only doulas, but potentially certified midwives and other practitioners in this space. But we have a lot going on. Sooner Select, as you can imagine, has taken up a lot of our time. One of the important financial reasons for going to Sooner Select was the supplemental payment increase that we're able to give our hospital providers, including our birthing hospitals. By going to the average commercial rate for their supplemental payments, we were able to get advance payments out to our hospitals using that new reimbursement methodology last week. And so we know that especially after the Change Healthcare issues that a lot of providers experienced disruption in payment due to the cyber attack on Change Health. We knew it was important to go ahead and get more cash infused to our hospital system, especially those rural hospitals. So those payments have gone out last week through our managed care plans. That's the majority of our updates, but happy to stick around and answer any questions if there are any.
Thank you, Trailer. Any questions?
Yeah, hey, it's
Trailer.
Tracy Clark. I have a quick question, and that is on the current Medicaid managed care model in obstetrics, is the obstetrical provider the PCP, or do they still have to go through a PCP for referrals?
Great question. So we in the medical home model that we administered, we took the referral requirement away for that. So even in our medical home model, that's not required. But I will say, I don't know if all of our plans may have different medical home models and how they define PCP, but I do know all of our plans are open networks. So they don't require referrals for any specialty service.
Okay, that's great. Thank you so much.
I'm also going to drop a provider resource link in the chat that keep this bookmarked. We add additional information regarding Sooner Select. There's very robust Q&As and guidance. If you have any questions in general about that, we try to update that page regularly.
Any other questions for Trailer? No? Okay, thank you, Trailer. We also have Teresa Stevenson here from the Oklahoma Department of Mental Health and Substance Abuse Services.
I sent you my list, but I don't have it in front of me, so I'm just going to go for it.
We have a slide. There we go.
Hey. Okay, good. We are working with the Opioid Response Network to bring in a prescriber learning collaborative, which will start in October. We did a survey and we received several responses back that from prescribers for medication for opioid use disorder that were interested in that. When we did some surveys of policies and procedures around the prescribing of medication for the treatment of opioid use disorder, we had some policies and procedures that were kind of all over the place. And so we thought this would be a good way to help each other learn from each other in Oklahoma. And so that'll start around October. Medication for opioid use disorder training for individual disciplines such as like district attorneys, child welfare judges. We are working with the Southwest Addiction Transfer Technology Center to create those, and those will be available, and we'll be able to house those on our website and have hopefully CLEs available for those. We have been working with the Chickasaw Nation with developing the family wellness plan. So it's very similar to our family care plans that we are working with our state contracted treatment providers and some medical community around. And it is really just helping to develop that for their system. And it's an in-depth technical assistance project that we are partnering with them on. We've had a lot of interest around our family care plan and our Tough as a Mother anti-stigma campaign work. And so we've met with Variety Care and North Care not long ago. And Variety Care, shared with us that they already kind of have this birthing plan and this kind of care plan. And we were like, that's perfectly fine. Just add that plan into the family care plan because it's for that individual to help that individual. And so we were very excited. And the fact they said they delivered over 3,000 babies last year was just amazing. So we're looking forward to continuing that conversation and work. And we have had some conversation with Duncan Regional as well. There's a lot of systemic barriers in that area. So we'll probably have to kind of walk back a little bit and look at how we can address those in the community coalition area for the systemic issues. However, they can still go ahead and work on their family care plan and the Tough as a Mother anti-stigma campaign, which they're also interested in. We entered an interlocal agreement with the Department of Corrections and the Department of Mental Health to provide medication-assisted treatment or medication for opioid use disorder in the prison setting. And there will be 2 pilots, one male, one female, in their reception prisons. And they will be screened and assessed about 6 to 9 months prior to release. And we know that the risk for overdose is very high in this population. And when they leave the prison setting and re-enter into the community. So therefore that we are starting with that small group because we are using our SAT dollars from Department of Correction to actually do the pilot. Otherwise, because I was like, oh, let's just do it all. I don't have the money, but let's do it all the way. And they were like, no, we can't do that. So we are actually subcontracting with an opioid treatment provider. That way we have all 3 types of medication available. That OTP will then go into the prison setting to do induction and to do dispensing, and they will be able to do their therapy sessions via telehealth. DOC already still has their programming that they will conduct, but it's a wonderful collaborative between these 3 different entities to provide these services to individuals that are in the prison setting that will be returning into the community. Another reason we use this contracted treatment provider was due to the fact that they will automatically have a referral when they go out into the community. They'll already be connected to that provider. And if they choose not to be with that provider, at least they have that connection. And then until they can get connected to a provider in their area that they are returning back to. There's a lot more, but that's all I'm going to do today.
Thanks so much, Teresa.
Yes.
I saw somebody, I don't know your name, Zoom user had a raised hand. Do you still have a question? You can come off mute.
That might have been me. I didn't take my hand down previously.
Thanks, Tracy.
It was me, and Teresa answered my question.
Okay.
Great, thank you. And I apologize. I have some men that are doing yard work that of course are right now outside of my window, but I think they're moving away. So if you hear any background noise, I apologize. I just wanted to provide some updates from OPQIC before we get into a couple of our invited speakers. We wanted to provide an update for Team Birth. As a reminder, we're the first state to implement Team Birth in all of our birthing hospitals. And we are doing this with support from the State Maternal Health Innovation Program grant through the MCH and HRSA. And if you'll go to the next slide, I just wanted to remind everybody of all of our hospitals. We began this work actually with our first hospital at St. Francis in Tulsa that was a pilot hospital for the feasibility study with Ariadne Lab. And now, as we are just beginning our 5th cohort. So you can see here over these last 2 years, we've been working really closely with all of these hospitals. And we have our next slide. These are our last 5 hospitals that we are launching for teen birth. So we will be the only state with all of our Oklahoma birthing hospitals that have initiated and are implementing teen birth. I do want to share just briefly, we will be publishing a manuscript, and that is probably going to be coming out in about a year, but the preliminary data from that and the significance of those patients who answered an increase in autonomy or experienced an increase in autonomy and trust with the healthcare team there's a significant difference and a clinical difference, we believe, from those who did or did not experience teen birth. So be on the lookout for that. It's really exciting, and we'll look forward, and we want to thank all of you all, because we couldn't do it without all of our birthing hospitals. We will probably have about 6,500 survey responses for that manuscript. So that's a really big deal, and we want to thank you all for working so hard on that. So with Teen Birth, we do want to share that they just launched this month a Teen Birth recognition program for hospitals. The link is on our website. We can share it in the chat, but this officially recognizes those hospitals who have had a successful implementation and demonstrate ongoing commitment to sustainability of the teen birth care process. The next slide, just want to show with Ariadne Labs. There you can see the website. There will be a formal recognition and a brief feedback on the teen birth implementation when the information is submitted. Your site will also be named on the Ariadne Labs website Wall of Fame, and we will also include your name on our website. And there will be a digital badge that you can add to information or marketing materials in whatever way you desire. So how do you become recognized by Teen Birth? There are 3 steps. The first one is to reflect and attest to the implementation components of the Teen Birth initiative. The second one is observing teen birth huddles and submitting the results. And number 3 is demonstrating ongoing commitment through an engagement activity. So a little bit more detail on these with the next slide. The attestation will have to, is a certain form that will be completed and signed by 2 people to attest that they are implementing teen birth with fidelity. There will be a requirement for huddle observations, and there's a form that you can fill out as you observe the huddles, and you will return those. And the number of observations is based on your birth volume. And then there are different ways that you can submit that you are committed to continued sustainability and engagement. So there are some examples here. One of the ways that our hospitals are planning on doing this, they are continuing to do patient surveys through, instead of being a part of the research project, but doing that through quality improvement, making sure that your new staff are educated on teen birth, and they can do more than one of these. So we're really excited about the teen birth recognition. We have one of the first hospitals already that will be recognized is OSU Medical Center in Tulsa because they completed the pilot project on this. So congratulations to OU Medical Center. And then we're hoping to see more of you all flow in here. And I know that Oklahoma will have the most hospitals recognized as teen birth hospitals. So thank you all for all of your hard work on that. Just wanted to provide those updates to you. I think that's all for me. If you'll go to the next slide. Yes, so thanks so much. We have Katie Harrison, who is attending tonight from the Oklahoma State Department of Mental Health and Substance Abuse, and she is going to provide information about our Tough as a Mother campaign. You heard Teresa Stevenson mention this. This is an anti-stigma campaign that we are doing in Oklahoma. And we want to make sure we share this with you and where you can find the materials and what you can do as a partner or as a clinician or as a hospital to help with create awareness of this anti-stigma campaign. So I will turn it over to you, Katie Harrison.
Thank you so much, Barbara. And thanks, everybody. I am Katie Harrison, and as Barbara said, I work for Department of Mental Health and Substance Abuse Services. The area that I work in is focused around providing family-centered substance use treatment services through all of our contracted substance use treatment providers. And one of the things that we have brought into kind of our toolkit is this Tough as a Mother campaign, and I'm going to talk to you guys just a little bit about that. I apologize to whoever's going to manage the screen because I'm going to try to not go fast, but I do tend to go fast, so I'll try to let you know. So if you could go to the next slide. Thank you so much. So what is Tough as a Mother? Put very simply, Tough as a Mother is a statewide public awareness campaign, and it's done in partnership with the state of Colorado. So kind of what happened with that is we were looking around for ways to address stigma within our own state, and we came across this campaign out of Colorado. And when we visited the website, we were really impressed with their messaging, and we felt like it could really have a lot of benefit within our own state. We reached out to Colorado Office of Behavioral Health, and they agreed to let us partner in that campaign. And since then, multiple other states had joined suit. And the goal, hopefully, will be someday that potentially this could be a national campaign. And put simply, you guys are aware of this, but why do we need an anti-stigma campaign within Oklahoma? Well, we know that the stigma associated specifically with pregnant and parenting persons with a substance use issue, along with potential legal and societal consequences, makes this a really difficult population to identify and to reach and to bring into care, whether that be substance use treatment or prenatal care. And so we really wanted to come up with a way to begin to address that and connect with this population. Next slide. So the tone of Tough as a Mother, it's very specific. We wanted to be sure that it was empathetic, that it was compassionate, empowering, and strengths-based. And you'll see a couple of examples off to the side. There's a couple of messages there that are a part of the toolkit that I'll talk to you about, just to really begin to spread the message that, recovery is to be celebrated and that we understand that it takes courage to ask for support. Next slide. We have three main goals around our campaign in Oklahoma. The first one, simply put, is to work on reducing stigma around mothers who experience substance use disorder. And I'm gonna, as we walk through these slides, I'll talk a little bit about how we're doing that. The second goal is to really reach and connect pregnant persons or moms with dependent children to family care planning and substance use treatment in their area, in their community. And then the third is we wanted to have one specific place that we could potentially offer resources to individuals, communities, and treatment providers around providing best practices for this particular population. And you'll see to the side there, there's a picture with some of the messaging included. And a QR code that leads individuals back to the website. Okay, next slide. Key messages. There's a couple of key messages throughout the campaign. One of them is being a mom's tough, but so are you. If you're using alcohol, marijuana, and or other drugs to cope with stress or trauma, you're not alone. Next slide. Putting yourself and your needs first is the most important step in not only working towards your recovery, but also in strengthening your family. We want you to know that you're not alone and you're not to blame. Substance use disorder is a disease, and much like any other disease, such as diabetes, Medical management is an essential part of treatment. And again, here's an image from the social media toolkit that's available online. Next page. So I'm going to take you through the website. Here's a link, and we can throw a link in the chat when I'm done, and then also be sure that you guys have access to this. I believe Barbara is going to send out the PowerPoint, so you'll be able to access the website. It is built into our OK, I'm Ready website, but it has a vanity URL. So when you follow that website, it'll lead you directly to this portion of the page. And I'm going to give a disclaimer that right now the page is a little bit out of order. We're doing some working on it internally, and I hope to have that resolved a little bit soon. And so what I'm going to show you today is the way it's meant to be laid out. And hopefully it actually will be laid out that way again very shortly. Somehow some things got moved around, and I caught that recently. So we're trying to get it back in place. Okay, but essentially when you walk to the web, or you walk in the front door of the website, this is what you're going to see. The message that this is hard, being a mom is tough. Support's available. Next page. Oh, sorry. And then off to the side, this is always kind of hard to see. So I put a circle around it. There's a couple of tabs there. So we have a Tough as a Mother tab. We have a Community Resources tab, a Moms Like You tab, downloadable resources, and a Treatment and Provider Map tab. People can also order naloxone off of this page as well. Next page. When you enter on the Tough as a Mother tab in that initial front door, what you're going to see are messages that are really targeted toward mom, right? So we're so glad that you're here. We know that this is hard. We know that a person needs to be vulnerable when they seek help, and that's not always easy. And that seeking support doesn't mean that they're required to go to treatment right away. That if they choose to get connected with a substance use treatment provider, they will work alongside them to help them create an individualized plan. And this is the first place on the website that we really begin to introduce the idea of a family care plan, which is that, you know, it's a living document, and it's a way for people to advocate for themselves and hopefully help them have a healthy pregnancy if they are pregnant, and potentially be able to keep their children safely at home with them. Next slide. Oh, sorry, one more. The second piece of this particular tab also is really geared toward mom. And you'll see there's a couple of buttons when they get to this section. There's a what to expect section, a why get help, and find a provider. So when you think back to the goals, those are some of the main things that we were hoping to accomplish with the campaign. So it goes into, you know, what does starting recovery look like? We're trying to begin to give, share messaging around what some truths around that are, you know, that we know that individuals have a lot of fears. And so we're really trying to counter that with some truths around what might happen should you walk in the front door of a treatment agency and ask for help. We also talk a little bit about why it's important to get help and what if you're pregnant. So there's some specific messaging targeted toward that. And then lastly, there is that tab right there where they can hit find a provider, and that will connect them to the next tab in the website, which on the next slide, I'll lead you guys through. So it is, go ahead and hit that for me one more time, sorry. It is the last tab. So off to the, off to the side where the tabs are, it is the treatment and provider tab. And this tab is really, I think, helpful in that it can be used by a variety of individuals. But let's say I'm mom right now, and I'm interested in seeing what kind of treatment and support might be available to me in my community. One thing I'm able to do via this particular area of the website is go in and enter my zip code, and it's going to populate with all of the Department of Mental Health contracted substance use agencies in their area. And all of those agencies are also contracted to assist them with developing a family care plan should they want one. Next slide. We have a downloadable resources tab. This tab houses a lot of downloadable Tough as a Mother resources, which are free. There's a social media toolkit that both organizations and individuals can make use of should they wish to spread the Tough as a Mother message. There are downloadable posters that have that stigma busting language incorporated, along with a QR code that can lead people back to the Tough as a Mother website. There's downloadable Tough as a Mother logos and Tough as a Mother rack cards. And as we move forward, this is a section that I'm hoping to continue to grow. But one of the things that we realized is that it would be really helpful should we be able to make these items available to individuals so that they could potentially work within their own community to figure out how to really spread the message and reach individuals to help them get connected to care. Next slide. Yeah, one more. Sorry, I put little animations in here. We have a Moms Like You tab. In this tab, here's an example. It's a little picture, but we've really been working to collect stories of hope from mothers because we really want to demonstrate moms with lived experience sharing their story of recovery to demonstrate to others that recovery can and does happen. And so we've been working to collect these, and it's something that we will continue to do. It is one of the pieces of the Colorado website that I thought really had some significant impact. I know that when I place myself in this situation or I speak to moms who are currently in this situation, this is an area of the website that seems to really speak to them. Next slide. Just one more. Okay, and then there's the community resources tab. We're almost through it. This area is that area where I really wanted to find a place to share resources. So this is an area that treatment providers or community partners can go in and potentially work with us to create videos to demonstrate what it might be like to walk in the doors of their treatment agency. We were thinking along the lines of the amount of fear that some individuals have within our state to make it known that they're struggling with a substance use disorder, particularly if they're pregnant. And so one of the things that Colorado had done that we also thought would be particularly useful in our state is to have treatment providers or community organizations introduce themselves via video to say, this is who I am, and I'm in your community. And if you were to walk in our doors, these are the ways that we could help you. This is what you might experience should you come in. And so this is an area for us to collect those. So if moms are interested, they could take a peek at what might be available to them and who those individuals might be should they walk through the front door. We also have training resources, information on accessing trainings around family care plans, and links to past calls and trainings around family care plans, again, for both treatment providers or really anyone in the community that would like to learn more about the family care plan process. Next slide. Okay, so that is a very balcony level view of the Tough as a Mother campaign. And then when I thought about it through the lens, as Barbara had asked me to come speak to you guys about, how specifically could medical providers and hospitals make use of the Tough as a Mother campaign. And I came up with a couple of ideas that were kind of specific to some experiences that I've had. So I'm going to talk to you about those. Next slide. So the first thing I'll ask is that we step back, each of us individually, to consider how our local OB offices and hospitals or health departments could be making use of the downloadable resources. So that is that specific tab off to the side where we're able to download the information. Okay, next slide. Oh, yeah. One of the things that I had been speaking with an individual with lived experience. So one of our treatment providers in Tulsa County and I had been speaking, and she had been a mom who was struggling with substances while pregnant. She's now in recovery and she's helping other moms through the process. But she had told me that she had some concerns about the work that we were doing because she just did not see any way that mom would be willing to divulge that she was using substances while pregnant for fear of what would happen. And she talked about visiting her OB while pregnant. And she said, there is absolutely nothing that would have gotten me to come out and share that I was using substances. And so I shared with her this material. And if you'll go to the next slide, also in another example of some materials that we have that are called rack cards. So that's the picture is the front and then the writing is the back. And I said, what would happen if you were sitting in that waiting room and you looked up and you saw a one-page poster, or you picked up a rack card and you read this messaging that was targeted specifically to you that said, putting yourself first and the needs of your family is the most important thing you can do. And we're here not to judge you. We're here to connect and help you. Do you feel like that may have made it more likely for you to be willing to be open about the things that you were struggling with? And she thought about it for a while and she said, I think that it might have. She said, I can't guarantee that I would have done it, but I know that it would have had a significant impact. And so when we talk about how medical providers or hospitals or health departments can make use of the campaign. To me, it's figuring out how potentially can we utilize these downloadable resources to reach individuals as they come in to seek services from us. So when I think about a hospital, I think about not only individuals that may be coming into birth, but there's that, but then also we know that people come in through the emergency department. So, and there's pediatrician offices and a whole host of other ways that people engage in medical care. So trying to determine for you specifically in your role, how might you be able to make use of some of these in order to best reach the population? Next slide. And the other thing is also another interesting personal experience that I had, but that is looking at how do we each potentially utilize the treatment and provider map to help identify local treatment and family care plan referral sources. I was visiting my OBGYN that last year, I think, and we were just chatting and I started asking a lot of questions. And I said, so kind of let's talk about common practices. And we were just chatting. I've known her for a very long time. And she said, the biggest barrier for her was getting people into care. She said, I'm identifying that around 70% of the people that I'm seeing in here are testing positive for something, mostly marijuana. And she said, but she was only aware of one referral source in Oklahoma County that was contracted with DMH and able to see anyone regardless of their status. And I explained to her that there are very, very many more others. And so to me, I recognize that there's, I think sometimes we're so siloed and we're not always aware of all of the opportunities that are available. And so the way that I see this potentially working within the medical community is that if you do become aware of someone who could benefit from being connected to treatment or to a family care plan, then either guiding them to this particular portion of the website or actually exploring it for yourself to help increase your knowledge base might be really helpful for you as well. Next slide. And then lastly, I just ended with, again, just really taking that step back and exploring what makes the most sense for your setting and how might you be able to utilize the campaign to assist us in reducing stigma and connecting moms and families affected by SUD to support in treatment. If anyone comes up with anything novel that I haven't mentioned, like you have a moment where you think outside the box and you're like, man, I really think we'd be able to do this. I would absolutely love it if you would share that information with me, because this is new and we're moving forward with it within different systems. And I think different systems can make use of this in different ways. And so the more I learn about these approaches, the more I'm better prepared to train and share with others. The last slide is simply my contact information. So if you guys have questions, I also have some downloadable materials that are already printed that I may be able to share with specific people if they would like. Please feel free to reach out to me. Or if you are struggling getting someone connected, please let me know. I'd be more than happy to assist in those cases as well. I feel very strongly about the work that we're doing, and I would absolutely love more partners in it. So if you can think of any way that you might be able to work this into your existing programs, I'd be happy to partner with you in it. And I'm here for questions if there are any.
Katie, there's a question in the chat from Hannah Ralston, who's with Tulsa Birth Equity Initiative. She asked, does participation in the programs / family care plans help prevent potential charges in the case of miscarriage or stillbirth?
I cannot say that it would, point blank. One of the things that, at least with child welfare, that I know that they've wanted to be sure that we're sharing is the message that there is no guarantee that specifically having a family care plan will guarantee any specific outcome. However, well, before I say however, I also have learned, Hannah, that the way this is being handled, county to county, is very different. And so while it could be beneficial in one county, I cannot guarantee that it might be beneficial in the same way in another county. But what I have seen is the counties that have been implementing them have seen significant positive effect as it pertains to infants being able to remain at home post-birth. I don't think we've collected any specific data around the charges, but that's an interesting thing that we might want to begin looking at.
Thank you. I was mostly just curious how that could impact.
I would love to say yes, it does. And I think so much of it will probably come down to location and kind of what's happening within that particular area. But I'd be really interested to see if we could pull some data around that. I'm not sure if we can, but I'd like to.
Yeah, that's a great question, Hannah, and we are hopeful it would, but we, again, like Katie said, we don't really know what the situations are and in the different locations. So we're happy to answer any other questions and talk with you more. I see another question that was answered in the chat. Any other questions for Katie Harrison? Well, we hope you all will make use of those Tough as a Mother, the campaign and the materials. There's a lot of really great stuff that's available for you. And so please, all of these resources we should have on our website. We are doing some updates. So if it's not available, if you can email and we will make sure it's added. But we want to make sure that you all see the OPQIC webpage as a one-stop shop, so you don't have to remember all these other places to go find everything. So please visit our webpage to find any of these other things. And if it's not there, let us know and we'll make sure we add it. I will say we are doing a lot of updates right now on this, the mental health and substance use disorder page. So that could be something that may be changing soon.
Well, thank you guys for your time. If you have questions, please reach out. I'm happy to answer them.
Thanks so much. And we also wanted to, we are in a partnership with Newborn Screening Program at the Oklahoma State Department of Health. And we wanted to let you all know everything that's going on in that program. There's a lot. And we have Sherry Arsenault from that program within OSDH, and she is going to provide you guys with some information on newborn screening in Oklahoma.
Good afternoon, you guys. Thanks for having me with you. And I'm trusting you can see my screen appropriately. Yes? Can I get a yes?
Yes.
Yeah, perfect.
Yes,
And see you.
All right, excellent. I have met some of you. I did a quick look through the chat attendance, and some of your names are familiar to me. Either I've been to see you at your hospital already, or I've talked to you by email and we're planning a visit. So that makes me happy to see your names on here. But it's been my experience in nursing when I was both the pediatric nurse and a hospital nurse ages ago, that my knowledge of newborn screening at that point was I just knew about these pesky little circles and how irritating they were to get exactly right. And my knowledge beyond that was pretty minimal. And I feel like that might be the case for some of your staff members as well. So I'm really hoping to give you a little taste of the depth of the newborn screening program and pique your interest to learn more, and we'll go from there. But who are we? The follow-up program at Oklahoma State Department of Health Newborn Screening. We have some new little images that we'll be using in some of our materials. So we consist of blood spot, our little footprint on the left, CCHD screening, pulse ox, and hearing. And all three of those screens, every baby in Oklahoma deserves to receive. And we work really hard on getting that information out. And I know that you guys do too. But I wanted to tell you about our follow-up team and who we are and a little bit about what we do. So the blood spot, particularly, that's the program I'm most deeply involved in. We have one program manager who manages blood spot and hearing follow-up. We have one assistant blood spot supervisor, 3 nurse consultants, 2 admin assistants, and then myself as educator and over quality assurance. So together, I didn't do the math, so 8 of us. We work on the daily follow-up out of all the out-of-range newborn results that come across from our state lab every day. So all the babies in Oklahoma, we get all of their out-of-range results, whether they're borderline out of range, significantly out of range, presumptively critically out of range, or whether they just need a repeat because their specimen wasn't testable for some reason. We communicate with our many partners, providers, parents, specialists, genetic counselors, hospitals, midwives, early interventionists, and more. We do community outreach and education, and we do hospital education and monitoring of quality measures, which some of you are already aware of. This next slide and the following one, I'm going to do these quickly and go back and forth, and they are overwhelming, and they are overwhelming on purpose. They still overwhelm me, and I've been in this role for 2.5 years, but this is a comprehensive list of the 57 different disorders that are currently on the newborn screening blood spot panel. The ones that are in red are considered to be time critical disorders, which means these babies can look great when they leave your hospital. They can go home and they can start feeding, and they can feed great, and mom can feed well and do everything right. And things can go wrong very quickly. And there's no way to be an expert on all of these disorders. None of us can be an expert on all of these disorders. That's why we have partners who are. But it's our job, state, to give you the parameters so that you can get the very best possible outcome for as many possible babies as we can. We cannot save every baby. We sure want to save every baby. And we set things up for you and give you goals so that you can do your very best to save every baby. One more distinction I'll make, the bold type on these two slides are primary disorders. That means that our public health lab is directly testing for these that are in bold type. All of the time critical ones are in bold type. The ones that are in smaller, more normal type are considered secondary disorders, and the lab identifies those while they're looking for the primary disorders. And so they identify them and they are treatable, and they report those as well. I'll also say that every disorder on the newborn screening panel is a disorder that is treatable. If there's nothing we can do for baby, we are not going to screen for that disorder. And there is a little bit, these may look disorganized, but the column on the left on this page is, these are all the disorders that can't really be categorized together. They're kind of standalones. And then on the right on this page are the amino acid disorders. And on this page, you've got your fatty acid disorders and your organic acid disorders. So that is just a very brief overview of all the different disorders. We have been working hard on our website. That's been a theme today. I've heard it several times. And there are places on our website that you can now go, and you can, on the provider section, you can go in and click on any one of these disorders and read a little bit more about them, what the emergency management protocols are for them, and really what happens in baby when they have these situations going on. So the quality measures that we focus on when we're working with hospitals and helping you identify how you're doing, there's several. The two I'm going to talk about the most today are transit time, and then the quality of the actual screen, the specimen itself. So why does it matter? That list that I showed you of the red and black screens, that delineation of the time critical, that comes straight from the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children's, the ACH-DNC. They meet regularly and decide actually which disorders that we do screen for nationally and on a state level. And then they make recommendations for how we follow up on them as well. But they are made up of expert opinions of metabolic geneticists, hematologists, endocrinologists, and pulmonologists. So I'm not randomly choosing these. These are been deemed to be time critical. So what does the Oklahoma State rules and regulations say about timeliness for newborn screening? There are two different criteria. First of all, the timing of the specimen itself. The optimal time to collect your first newborn screen specimen, and maybe only, is as soon as possible after 24 hours. So ideally 24 hours plus 1 minute is your goal. It's not obviously a target that we expect everyone to meet, but that's your goal, 24 hours plus 1 minute, or immediately prior to discharge. If you have a mom who is extremely eager to leave and she's going to go home before 24 hours, then you want to go ahead and get that first newborn screen. The second criteria, or benchmark that we have adopted as a state is that every specimen, every hospital is responsible for getting a procedure in place that gets every specimen arriving at the state health lab within 24 to 48 hours of collection. So 24 hours of age, and then it needs to get out the door as quickly as possible. We go over a lot more detail at a site visit about how to dry, where to dry, all that kind of thing, but I'm not going to go over all that today. But 24 hours of age, and then we want that specimen there, but then 24 to 48 hours of collection. So here is a very busy slide, and you're not going to read those numbers in the green, and you don't really need to. I just have put here, this is a graphic of our 44 hospitals. Actually, these are just our hospitals that have 7-day courier. Our 5-day, we have 5 hospitals that only have 5-day-a-week couriers. But 39 of us have 7-day-a-week courier coming to your door every 24 hours. Not, I mean, I would love to say on a schedule. They have a time when they're supposed to be there. So you should know approximately when they're going to come. And if you don't know, then I want you to let me know that, because we'll work on that from this end and troubleshoot. But all these green bars that have a lot of gray showing or pink on the end, those are hospitals that are not meeting their benchmark for timeliness for getting the specimen to the lab. I purposefully did not put the names of the hospitals on here because that's not what I'm about tonight. This is all on your Tableau dashboards. You can all look these up for yourselves about your hospital. You actually can see every hospital. So there's a little bit of healthy competition, I would hope, that you can see if my partners can do this. Surely we can find a way to do it. So the reason I've posted this, so the pink on the end, that is the area, that's our sweet spot. That means if you have over there in that far right side, you are getting 95% or more of your specimens are actually getting to the lab within 24 to 48 hours. If your green bar is not over there and it's looking like a lot of gray on your line, something's wrong in your system. Somebody who is managing or treating or picking up these specimens, they are missing the information on the critical piece of timeliness. And I really suspect that most of the time it's we don't know what we don't know. So it's a matter of looking to see what are our processes, what are we missing, that specimens have been collected and they're not getting out the door with the courier the same day that they were collected. Really, they should go out the same day. The only reason if they shouldn't, say your courier pickup time is 10 in the morning. Well, if the specimen hasn't dried for 3 hours yet, then it can't go. But if it's been done the 19, 20 hours prior to pickup time, it should go out the door at that next pickup time. You don't have to wait for a site visit to start troubleshooting. If you look at your statistics on your Tableau dashboard and you can see that you guys have some trouble, then I would start talking with your key players. And I have learned with my hospital visits I've done so far this year that many of our hospitals do things differently, and that's okay. Some labs are involved, some labs aren't involved. Some labs collect the specimen, not a lot, but a couple. Some units handle all of it from start to finish. They are on the unit. So there's a variety of ways to tackle it. But I recommend you get all your key players and start talking about what your processes are and where you can make improvements to improve that timeliness for getting the specimen to the lab. Because what we don't want is these specimens that are hanging there in that gray area. If those are critical time specimens, if those babies have any of those critical timed disorders, we are going to have a lower chance of being able to save those babies. The other thing that we help you keep up with is your sample quality. And this is also in your Tableau dashboards. If you're listening right now and you don't know what your Tableau dashboard looks like, or you don't know who in your facility has access to your Tableau dashboards, feel free to email me. I'm going to have my email address on a future slide here in a minute. I'll be very happy to communicate with you and help figure that out. But I thought I would just throw up here where we are so far for 2024. So we to date have had 12,000 specimens, 156 arrive at the lab. 443 of those specimens were not testable for a variety of reasons. So that's an unsatisfactory rate of 3.64. Our goal as a state is to have less than 2% of our specimens be unsatisfactory for testing. So we're not quite there as a state. Some of you do exceedingly better than that. Some of your unsat rates are less than 1 and 0.5%. Some of your unsat rates are quite a bit higher, and that's how we end up with an average of where we are. Other information that you can find on your dashboard, just for information, the blue bars on the right, there have been 44 babies this year who have been identified to be at high risk for one of those disorders that I showed you on the newborn screening panel. 230 of them were identified to be at low risk. Most of those turn out to be just a repeat screen and not necessarily a critical disorder. And then incidentally, we have also identified 276 hemoglobin traits throughout those babies. So good information to have. Your Tableau dashboards has specifics for your own hospital. It is historical. You can flip back months and months and years and see where our trends, when did we do this well? What were we doing then that we're not doing now? So some questions that you can begin asking yourselves. My goal that I've been tasked with and I'm taking to heart is to physically get to every birthing hospital in 2024. And I've made myself a pie chart because I thought it'd be fun to see some color. And 11, the green, that's where I've been. I've completed 11, seen 11 of your facilities and your processes. I've learned a lot. I appreciate that very much. The yellow, I've got 16 more on the calendar. We are booked and ready to go. I have one invite hanging out there waiting to hear back from you. And then I have 16 more that I will be reaching out to you guys in the next couple of months. If you have not talked to me yet and you're ready to book your appointment, your newborn screening visit, it is I say we spend about 2 hours together. And the players who need to be at the table are your mother baby leadership, your NICU leadership, if that applies to you, your quality or regulatory compliance staff, and your lab staff. And I also say too, if you have nurses who are interested in becoming newborn screening champions in your facility, or staff that are just extra interested, I welcome as many of your staff as you want to be at that visit. I welcome that. So you can keep that in mind. And then here's a visual of where I've been and where I hope to get. The yellows are scheduled, the greens are completed, and then I'm trying to get an answer from Durant. I'm trying to talk to Alliance Durant. So if you guys are on this call, answer my email, give me a shout. I'd love to talk with you guys. Are there any questions for me? Oh, here's a few tips, things to do to maximize your site visit. Make sure you include all your stakeholders, get them to the table. Set aside your 2 hours, take a look at your Tableau reports ahead of time, and expect to expand your understanding of the system of a whole of newborn screening. It's so much bigger than a lab test. And what I don't want you to do is I don't want you to feel like you have to scramble to get your house in order. This is not regulatory. This is educational with a intent to be helpful. And there's no reason to panic because we all share the same goals of providing safe, quality, timely screening for every baby born in Oklahoma. So if you're ready to get on my calendar, or if you've got questions about your Tableau reports and how to view them, you want to see how your facility is doing, feel free to email me right there. Oh, there's more. I was going to stop talking. So maybe I've gotten you interested in some more information on newborn screening. We have a whole day's worth of information that I really think a lot of it will be new to most of you. We are tackling our very first newborn screening statewide symposium. We are so excited. May 24th, but from 8:30 to 5, it will be a full day. We will provide you lunch. And our target audience are newborn screening parents, which these are families who have been affected with and are living with some of those disorders that were on those 2 pages that I showed you, some of these disorders and of a variety of reasons. And we expect to have probably 15 to 20 different storyboards posted around the room with these families highlighted so you can see what these disorders actually look like in real life and in a day-to-day, year-to-year basis. We will have a family panel who will be answering questions about newborn screening and their experience. We hope to have family care providers and some information on how to communicate newborn screening results, things that are great to say, things that are not as great to say. Specialists, birthing facilities, midwives, county health departments, you are invited, and we hope you will choose to spend part of your day. I wish I could say send as many as you want, but we do have a large audience. So at the moment, we are asking hospitals that have NICUs to go ahead and register for as many of 2 of your staff members. Birthing hospitals without NICUs, we're asking you to register 1 at this point. And if I have the ability to open up more hospital spots, I absolutely will. And I will email hospital leadership and let them know that. We'll be watching our registrations. We just want to save some space for all the different constituents that we are inviting, so we can have a very well-rounded experience that day. It will be in Norman at the NCED Conference Center. And how to register. Couple ways you can do that. Here is a preview. Our landing page is also being updated. So you can just Google Newborn Screening Oklahoma, and you're going to get to a page that looks like this with these babies across the top. On the bottom, across the left-hand side, down at the bottom, there's a really visible link, 2024 Oklahoma Newborn Screening Symposium. And then our OPQIC partners will also have a link on their website that you can use. So we are getting registrants, and we're excited about it. And we hope that you will also plan to join us.
I do see a question, Sherry from it asks, what do your follow-up visits look like? And these are for mothers and for the child. Do you see it? Okay.
I sure do. And that's a great question. So at the newborn screening follow-up program where I am, we serve as a connector of the appropriate specialist for the disorder in question to the family and the PCP. So I have never actually been to a follow-up visit at the specialist office. I do work closely with the staff in those offices, so I can only imagine how that they are compassionate and thorough and kind. I do think that follow-up for moms initially is terrifying. I feel like the information they receive on the front end, we all Google things. So if you find get information about a scary disorder, the first thing we're going to do is start to research it on our own, and we know how scary that is. But the way parents learn about newborn screening out of range results best is from their PCP. So our goal when we have an out of range is we contact the baby's PCP, which is why we need you to write it clearly on the demographic form that you fill out for us. And then that PCP reaches out to the family and gives those results. At the same time, if it's a critical result, we are reaching out to the provider, to the specialist, the appropriate specialist for that disorder. So we have contracts with endocrine, genetics, immunology, pulmonology, hematology, and neurology. And those are all the specialists in town, both in Tulsa and in Oklahoma City, who would manage the babies who could potentially be diagnosed with those disorders. So we work very hard to connect the specialist with the PCP almost immediately. And the specialist then gives the PCP the next steps. We need to get lab work now, or you need to go to the ER now, or sometimes baby's already in the ER and we're giving them information on what direction do we need to go? What do you need to be looking at with this infant because of the way they flagged? Does that answer your question?
So yes, it does answer my question, and it has 1,000 more questions because you answered it very, very well. And I have a feeling I will be emailing you to ask and talk about these things, because the first thought that popped into my head is, well, that's an awful time for a family. What kind of mental health supports can we offer to that family as part of that referral process? But I digress significantly. Thank you for answering my question.
You're welcome. And I see your follow-up question, and I have to apologize if my coworkers see when I made my little slide of who's part of our follow-up program. We actually have 2 new staff members. We are developing a brand new long-term follow-up program. So to answer your question about how do we connect families, yes, once they are diagnosed with a disorder, we have staff members who are actually building now our long-term follow-up program, where we hope to follow these babies until they at a minimum until they are enrolled in school. So we'll be checking in with parents annually. They'll be checked in with by their providers, of course. They'll be connected, hopefully very well, to the medical providers, but we want to reach out to them annually to say, are you accessing support groups? Are you accessing this and this and this other ways that we can support them as a state? So that's a huge thing on our radar right now. So I'm glad you asked the question. And then the very fact that you said this is a terrible time, a terrible thing for families and a hard thing for families. One thing that I feel like we can do better as a state as well is educating moms about newborn screening as a whole prior to the time that they hit your hospitals, because we know they're not going to learn well while when they just delivered a baby, whether they just had surgery or whether they just endured labor and delivery. Their brains are not fully engaged just because they're overwhelmed and systems are all go. So it's my dream that every mom knows about newborn screen before she gets to the hospital. So we have a lot of work to do in that way. I don't have a lot of inroads into our OB population. That's a wish list of mine. If any of you have great contacts with OBs who you feel like would be happy to start putting some educational material in their offices, send them my way. I would be happy to provide them with that. We have some great RAT cards that would be perfect. So it's just a matter of getting that out there and making it normal that, oh yeah, it's the newborn screening test. I can't wait to hear what it is. I want to get my baby's results, instead of just not being totally caught off guard about the whole thing. So anything else?
Thank you, Sherry. That was very helpful. And we have information on OBs. If you have others, please share them. And this was really helpful. I think, yeah, a lot of people just talk about the PKU, and that used to be one test we would do.
Yeah.
But as you said, I think you said 57.
57. I should have pointed out the PKU is one of the amino acid disorders on that slide. So it was on there. It's just that it's one of so many. You might as well call it the cystic fibrosis or call it the congenital hypothyroidism or the MCAD. It's just not the PKU. It's the newborn blood spot screen. So
yes. So I think we need to change our language so we can give credit to all of the different conditions that are being, that we're testing for, including the critical congenital heart defects and the hearing screen. And Sherry is here to help. We are here to help connect you if you need to be connected to Sherry. I put her email in the chat, and please reach out to her if you have any questions or would like to schedule a visit, or just like she said, any opportunity to share the information to those who are currently pregnant or anyone else. Just, I think it's helpful to create the awareness for what this program is all about and the importance and the comprehensiveness. So you'll find out more if you're able to attend the symposium, and Sherry is very helpful coming out to your hospitals and helping you with this. So we are really thankful for you, Sherry, for sharing this information tonight.
Absolutely.
Are there any other questions for Sherry? Okay, well, that is the main agenda. I do have a couple of brief slides to share with you all. If Denise, you can advance, or Sherry, yeah, turn it back over to us. Thanks. I forgot. Thanks so much. I just want to make sure everybody's aware. We constantly hear, I didn't know about this. So making sure that everybody is aware of these important resources that are available to you to please share with your patients. This is the maternal mental health hotline that is available, and please make sure you're sharing that with your patients. We have a way here that you can do that. If you'll look at, go to the next slide. Oops, I put these in the wrong order, but I'll wanted to remind you all about the low dose aspirin in pregnancy project. And Melissa Ward is available to come to your office and talk about all of our resources, provide the toolkit and information with you. We want to ensure that everyone who is a candidate to receive low dose aspirin in pregnancy to reduce the incidence and severity of preeclampsia, that they're all receive a prescription for aspirin and are taking their aspirin up until delivery. So Melissa is available. Her contact information is there if you want to find out more. We got lots of great materials, and this information, this project is supported by the George Kaiser Family Foundation. And then the next slide, here's our Empowering Pregnant and Postpartum Patient Toolkit. So make sure, Sarah's going to be reaching out to hospitals to get everyone engaged in this program. That this is one of our key things that we find in the Maternal Mortality Review Committee is patients may not be aware of when and how to seek care. So ensuring that everyone is educated on urgent maternal warning signs during pregnancy, that they're re-educated on post-birth warning signs before discharge from the hospital, that they're provided with this other information for helpful information that all patients need to know. There you can see the maternal mental health hotline there, and that they receive a clinical summary of what happened during their birth experience. So please visit our website to find these. And Sarah also has a form there if you want her to come visit your hospital. Our next resource, just want to make sure you guys know here's again that link to the survey, Title V survey, so that you all can provide your input. It's very important so they can prioritize what areas to support with Title V. And we should acknowledge at OPQIC, we do receive funding through the State Department of Health that is Title V funding. So next slide, I think that's it. Are there any other questions from the attendees or any other business that we need to address? Please unmute yourself, or you can ask a question in the chat. Any further reminders of other events? We do have the A1 Oklahoma Section Conference coming up next week on May 2nd and 3rd. If you would like to attend the Association of Women's Health Obstetric and Neonatal Nurses Oklahoma Section Conference. Well, we would encourage you, a good way to also stay up on what's important, if you'll go to our next slide. To attend all of these meetings, our next one will be July and then October. If you want to get registered for all of them and have a calendar invite placed, you can go to our website there to register for these meetings. And we have upcoming events. Don't forget about the OSU Project ECHO, maternal health. ECHOs are the first and third Thursday of every month. And what Sherry had talked about, the newborn screening symposium. But thank you for joining us. I want to share all of our social media slides. That's channel. This is a really good way to stay caught up on what's going on in the world of perinatal care, not only in Oklahoma, but nationally. So please follow us on all of our social media. We also have a LinkedIn page now too. We'll make sure we update that. And we will be sending you a follow-up email with a recording and a copy of the slide deck. So thanks everyone for joining us, and I hope you all have a great rest of your Tuesday evening.